So now we're going to discuss history taking. Again, another very important piece of the patient assessment puzzle is to get a good history, both past medical history and history of the events of why you're there. So the history provides detail about the chief complaint and the patient's signs and symptoms. Remember, a sign is something that you can see or measure. A symptom is anything the patient tells you that is very subjective or that you cannot see, such as pain, for example. There are some nuances about the questioning of the patient. It's important to introduce yourself. Most of the people you're coming in contact with do not know you before you walk into their presence. So it's important that you try to develop a rapport with them as quickly as possible. And part of that is introducing yourself. You want to ask them for their name and pay attention to this. This is how they typically want to be referred to. So, for example, if you have an older person, they may say, call me Mr. Jones or Mrs. Smith. They may say, call me Sam. And so, therefore, that gives you permission to call them by whatever name they want to, or whatever name they want you to. And it also helps to, again, develop that rapport with that patient. So you want to refer to them as Mr., Ms., Mrs., using their last name, especially if they are older than you, unless they give you permission to do something else. They may give you that permission to call them by some other name. Obtain permission to treat them before you touch them. So a very simple, hi, my name is Mike, I'm a paramedic. I'm here to help you. Can I examine you? Can I check your blood pressure? Can I, can I wrap that wound for you? So developing or getting that permission to treat them before you actually touch them. You want to ask open-ended questions unless the patient is somehow obtunded, meaning that they can't comprehend that open-ended question, or they cognitively can't understand what you're asking. But most of the time you want to ask open-ended questions so that you get more than yes or no answers. If the patient's unresponsive and can't answer, get information from the family. It's very important. Again, like I mentioned earlier, family and bystanders can be a good source of information for you. You want to use the mnemonic OPQRST to assess their symptoms. And here's how that works. O is for onset, so you want to find out when their symptoms started. P is for provocation or palliation. So is there anything that makes their symptoms worse or anything that makes it better? Q is for quality. So is it sharp or dull? Stabbing, for example. R is for region or radiation. So you want to find out exactly where their symptoms are. And is there radiation? For example, if they have pain, is there radiation to that pain? Does the pain start in the abdomen and go to the shoulder, for example? As we will get into some medical conditions, this is a clue that can lead you to determining what might be wrong with them. S is for severity. So how severe is it? If they're having pain or discomfort, this is where you would want to use a pain scale, 0 to 10 pain scale. 0 being no pain at all, 10 being the worst pain you could possibly imagine. And where does it fall on that? This is not, this is a very subjective determination, and whatever they say it is, then it is. Because it's their interpretation of that. And that severity of that pain scale will help you throughout the encounter with that patient to determine if their pain is better or worse. Timing, T is for timing. So when did their, how long has the symptoms been going on? When did it start? anything having to do with the timing of the incident. You want to ask clarifying questions of associated signs and symptoms that are related to the OPQRST. So if there's something you don't understand or you need something clarified, feel free to ask those types of questions. Pertinent negatives are very important. Pertinent negatives need no treatment, but they are helpful in identifying the problem and choosing appropriate treatment. For example, if my patient had chest pain, but it was only in the center of the chest and did not radiate to the jaw, for example, that's important. If I've got belly pain, abdominal pain, and I haven't had any vomiting or diarrhea, those are pertinent negatives. Those are important in trying to identify what's going on with the patient, but they're negative findings. The sample mnemonic is also a common thing that you will use on a regular basis, so it's important both to learn the OPQRST and the sample mnemonic. You do not want to go up to a patient and ask what their sample is. That is not appropriate. They don't know what sample is. They haven't read your textbook. So S is for signs and symptoms. So you want to find out what their signs and symptoms are. A is for allergies. M is for medications. P is for pertinent past medical history. L is for last oral intake. And E is for events leading up to the injury or illness. So again, you want to ask these questions, for signs and symptoms, what kind of problems are you having today, those sort of things. Do they have any allergies to medication or other environmental allergies, which might be pertinent? If you're dealing with respiratory problems, they may have seasonal allergies or asthma that may cause a problem. Medications that they take. Many patients do not understand why they're taking the medications their doctor has prescribed for them. So it's important that we get a complete list of medications. It is not adequate for someone to tell you, well, I'll take it with me, or we'll get it to the hospital, or the doctor has it. The doctor doesn't need it at this point. You do. So it is important, even if you have to write these down, to get a list of medications and dosages and how often they take them. Pertinent past medical history is anything that is pertinent to the incident. So that could be wide-ranging depending on the age, sex, and type of incident that's going on. Last oral intake is very important. Especially, first of all, if they're going to have any kind of surgery. If we think they're going to have some type of surgery at the hospital is going to want to know when they had their last oral intake. But also, if they're having some sort of gastrointestinal problems, we want to know that as well. And then the events leading up to the injury or illness. What were you doing when this occurred? What was going on when this occurred? That sort of thing. So critical thinking, clinical decision making, and differential diagnosis. These are things that many years ago used to only be dealt with, or we used to only think of with physicians, nurses, and paramedics. However, EMTs also need now to begin to critically think, know how to make clinical decisions, and understand what a differential diagnosis is. So the goal of the patient assessment is getting a history, doing diagnostic testing, is able to be open to get some idea of what is happening to the patient so that you can make a differential diagnosis and then make decisions on how to manage that problem. So we do this by, number one, gathering facts, which we've talked about with our history, things we've talked about with our OPQRST and our sample history. Evaluating those facts. So again, not just gathering the facts and forgetting about them, but we're going to evaluate them. And then we're going to synthesize that information that you've gathered and evaluated to plan some scene management and patient care. History taking on sensitive topics, alcohol and drugs, The signs may be confusing, hidden, or disguised, so it's important that you maybe ask direct questions. Patients may deny having these problems. The history gathered may be somewhat unreliable. It's important that we not be judgmental. We're not there to judge our patients. We're there to take care of them and get them to the help that they need. We always want to be professional in our approach. If we're dealing with physical abuse or violence or human trafficking, we want to make sure that we report all suspected cases to the appropriate authorities. We don't want to accuse or be judgmental. We probably don't know all the facts that have been going on. And if you're thinking that human trafficking doesn't occur in rural areas, you're sadly mistaken. So it is here, and it is close by. It's important to get a sexual history for female patients of childbearing age, especially those with abdominal pain, to determine if they may be pregnant, unless it's ruled out by history or other information. So you want to ask the following questions. When was your last menstrual period? Are your periods normal? If the patient is having vaginal bleeding, ask how many sanitary pads or napkins have been used. So that's important to know, so that you can pass that information along to the physician at the hospital. You want to find out if they have any urinary frequency or burning. What is the severity of any cramping that they may have, and are there any foul odors? You want to find out if they're sexually active. Anyone of childbearing age, we need to know if they are sexually active, if they are giving us, if the problem they've called us for has anything to do with the reproductive system. And is there a possibility that you may be pregnant? Again, another question to ask, depending on the need. Are you taking birth control pills? You want to inquire about urinary symptoms for male patients as well. Male patients can have urinary tract infections, so it is important to ask these symptoms. When appropriate, ask all patients about the potential for sexually transmitted diseases. And looking at special challenges in obtaining patient histories, if a patient is silent, be very patient with them. Patience is extremely important. Remember, older or elderly patients may not be able to cognitively process your question in the time that you think it should be processed. So give them an adequate amount of time to process your question and then give you an answer. If someone just does not want to talk to you, try using closed-ended questions. The goal is to get as much information as possible. So if you are, under normal circumstances, we want to use open-ended questions so we get that information. But occasionally you may have to ask closed-ended questions if the patient does not want to talk to you. Consider whether the silence is a clue to the patient's chief complaint. Some patients are going to be overly talkative, and here's some reasons why. They could have had excessive caffeine consumption. They may be nervous. There may have been ingestion of illegal drugs such as cocaine, crack, or methamphetamines, or there may be an underlying psychological issue. For patients that have multiple complaints or symptoms, this is often true of older patients. Anyone that has multiple medical problems could have overlying symptoms. For example, someone that has a cardiac condition could also have difficulty breathing. So they may have chest pain and difficulty breathing at the same time. You want to prioritize complaints as you would in triage, beginning with the most serious. So if someone is complaining of chest pain, and while they were going to the phone to call 911, they stumped their toe on the table, they may very well be complaining of a broken toe. but that broken toe is not going to kill them, where the chest pain or the ischemic chest pain may very well kill them. So it is important to prioritize those complaints and work down through those various complaints. Patients that have anxiety, they may be pale, they may be diaphoretic, which is a sweating type of response from the body, and we'll talk about that later. They may be short of breath. They may have numbness in their hands and feet, and again, we'll talk about why this is later in the class. They may be dizzy or lightheaded. They may have had a loss of consciousness. For patients that are angry or hostile, friends, family, or bystanders may direct their anger and rage to you. So it's important, again, that you maintain good situational awareness and be aware of how family, friends, and bystanders are acting towards you. This is especially true if a patient is dead and you have to tell that family member, bystander, or friend that. You need to be very careful with that. You want to remain calm, reassuring, and be very gentle with them. Again, don't be judgmental. It's not our job to judge. If you're not safe, leave or call law enforcement. For patients who may be intoxicated, do not put them in a position where they feel threatened. Patients can go from being friendly and talkative if they're intoxicated to being very hostile and very violent very quickly if they are feeling threatened. The potential for physical confrontation is high with people who are intoxicated. Alcohol tends to dull the patient's senses, so it is important to understand that. For patients who are crying, they may be sad, in pain, or emotionally overwhelmed. It's important for us to remain calm. We want to be patient, reassuring, and confident, and we want to maintain a soft voice. We want to attempt to bring their emotions down somewhat from their crying. So we want to maintain, we don't want to holler and yell at them. We want to maintain a very soft voice and try to bring their emotions down. For patients that suffer from depression, depression is among the leading causes of disability worldwide. Symptoms of depression may include some or all of these, which include sadness, hopelessness, restlessness, irritability, sleeping and eating disorders, or decreased energy levels. You must learn to be a good listener. It's important. Sometimes when you are at a patient's home or wherever the patient's at, sometimes they want to tell you things. And so it's important to learn to be a good listener so you can determine exactly what might be wrong with them. Confusing behavior or history. Consider altered mental status and its causes. So anyone who is confused, again, going back to what I said earlier, you want to find out what a person's mental status is normally. And if you've determined that they do have an altered mental status, it could be any one of these things and others as well. Hypoxia, which is low oxygen levels in the body, and especially in the brain. It could be a stroke. It could be diabetes. It could be trauma, medications they're on, or maybe they've taken some illicit drugs. Older patients could also have dementia or delirium. For patients with limited cognitive abilities, we want to keep questions simple. We want to limit the use of medical terms. You may only get partial answers, but keep asking questions. This may be where you have to ask closed-ended questions. You want to rely on family, caregivers, and friends to fill in the gaps or answer questions for you. Sometimes cultural challenges can, be a challenge. We want to limit the use of medical terminology. Patients may prefer to speak with a healthcare provider of the same gender. This is often a cultural or religious preference. We want to gain assistance from friends or family members. If you have healthcare providers of the same culture, enlist their help as well. For language barriers, we want to be aware of language diversity in our community. Healthcare organizations who bill CMS are required to have interpretation services. Determine if the patient understands who you are. Keep questions straightforward and brief. For patients who are hearing impaired, we want to ask questions slowly and clearly. Again, if they are deaf, they will not be able to understand you. Most deaf people do not read lips, so that's something important to know. We want to learn to use simple sign language if you know it. If not, it's not that difficult to learn some basic signs. We want to use pencil and paper if the patient is able to. So sometimes the easiest thing to do is to get out paper and pencil and ask the patient to start writing down where you write a question to them and they answer it. This does slow things down considerably just because of the writing and writing questions and writing answers. But sometimes it will give you the best information and that patient will not feel threatened. Patients with visual impairments, you want to make sure you identify yourself verbally when you enter the scene. This is very important. You got to remember they can't see you. You want to return any items that have been moved to their previous positions. People who have visual impairments know where their furniture is at, they know where their chairs are at, and that sort of thing. If we move something when they return home, they may fall over that and injure themselves. So that's why it's important to return those items to where we got them. We want to explain to the patient what is happening in each step of the process. So what questions do you have? Write down any questions or anything you don't understand and bring it to class.